Good evening. So it's a pleasure to start this webinar on COVID-19 pandemic, looking through the ICU perspective on surveillance, ICU management, and research opportunities. We are very happy to have you all here logged in, and we are going to have three brief presentations. The first presentation will be from Dr. Dave Dongermans from the Netherlands. He is from the MC Intensive Care Unit, and he's also running the National Intensive Care Registry in the Netherlands, and he's going to talk about surveillance and national registries. Following his presentation, I am going to present on intensive care management, the challenges for COVID-19. I'm Jorge Salu from Rio de Janeiro, from EpiMed Solutions, and also from the Door Institute for Research and Education. And finally, last but not least, we'll have Professor Geert Mayfreud from Leuven, and he's going to discuss research opportunities, and he's going to introduce several of the protocols that he's running with his team on the COVID-19 pandemic for intensive care units. So over the next minutes, we'll try to have 10 to 15 minutes talks, and then after all the talks, we are going to take all the questions from the audience and be able to discuss and debate. And I strongly encourage you to, during the presentations, send us all your questions through our chat, and then we'll save the questions for the later discussions. So thanks a lot, Professor Dongermans. It's my pleasure to introduce you, please.
Thank you, George, for introducing me. As you said, I'm from Amsterdam. I'm an intensivist and working for quite a while now on the National Registry in the Netherlands. And when we heard of a strange disease in Wuhan, we got together in the registry and thought, maybe this is something we need to do something with. And at that point in time, we didn't have a plan yet, but we were sure that we needed to do something. And as it works with nerds all over the world, you talk to them and then you put something in their head, and after a little while, they'd come up with, well, maybe we could do a little inquiry into whether or not people will share their patients, their COVID patients, with our registry. And so that was just the idea. And what happened after that is that it turned out that the Dutch government really wanted to have a good view on how many ICU patients there were. And that was not surprising because, as you all know, I shouldn't say almost, but in a lot of countries, the problem is, are there enough beds? Are there enough ICU beds? And we'll talk about it a little later and how we in the end work this out. What I want to show you first is, where are we looking at for the Netherlands? I hope that George will show you some other numbers, but there were only, between brackets, 12,000 patients in hospitals in the Netherlands. So that's less than 1 promille, or 0.1% of the inhabitants of the Netherlands. That turned out to be 3,000 people in the ICU, 1,000 deaths, and 6,000 deaths in total. And of course, those numbers are not precise. They're just to give you an idea of what was happening in the Netherlands. And the first thing we also were asked to do was not only look into ICU patients, but also patients on wards, because, well, you can have enough ICU beds, which is, of course, I should always say, a bed is nothing without a nurse. So I would say you need nurses or personnel, and the bed that's easily arranged. So the worry was, of course, ICU beds, but there was also a big worry about beds in wards. And here is just to show you what happened during the wave which hit the Netherlands. We call this our first wave, and I hope it will be our last wave as well. But here you can see that around the 28th of March, the number of patients entering the hospitals was 550. Well, for some of you, this might not be a big number, but in fact, it's a whole hospital which arrives at one day and needs to be taken care of in a ward. Is that where again there's a quite steep slope. Slowly the number of patients diminished, and at the moment in time there are a lot of ICUs who do not have COVID patients anymore, and also wards were empty, luckily. This is how it went on the ICUs, and the way we tracked this was not with our normal system. Is that every month everybody does an upload on the patients that were present in the ICU. And we felt, and with us, of course, the Dutch government, that a month delay, well, just look at this graph, will tell you nothing. So we needed to have a day-by-day update on patients in the ICU. And what we did was we asked just a simple question, what is the age of the patient? Is it a male or a female? Is it a proven patient or suspected? And it was quite unique. As you all know, the privacy rules in Europe are quite strict. But due to the request of the government, we could use the personal identifier for the patients in the registry. And so we use those four just to show the numbers of patients. And now you see over the whole country, but we also could say by region. And of course, for Brazil, our country is a region. I do understand, but even in the Netherlands, we have regions, strangely enough. So we could show people who were interested in special regions. We had one hotspot, like Manaus is in Brazil. We had Brabant in the Netherlands. So there's more information than only this, and we could show it to the relevant parties. What you also see is that at one point in time, so just before the beginning of April, 30th of March, there are 128 admissions to the ICU. And for us, for the sizes of our ICUs, that means that there are 3 large ICUs filled with patients in one day. So there was a little panic at that moment in time. And still we had enough ICU beds, but there was sort of, well, the nurses especially, and I think they were right to do so. They said there is a cap on what we can do. We can't have more than, in the case of the Netherlands, 2,400 beds. And it was like the line that was drawn and where everyone was looking at. So are we able to keep, to flatten the curve and keep below 2,400 ICU beds? And the first thing, of course, which needed to be monitored was the admissions to the hospitals, because of course that when that flattens, you know that the ICU will flatten after that. And so that's what we tracked. And you see that at some point in time, around 2,500 patients were in hospitals, excluding ICUs. In the ICUs, you see that the high point, how do you call it? Well, the highest point of the wave, there were almost 1,300 patients in ICUs. And just imagine that we started out with 1,150 ICU beds in the Netherlands. So all the ICU beds in the Netherlands, plus a little extra, were COVID ICU beds. And then there were around 700, let's just call them normal or non-COVID patients. So there was an enormous strain on the system. One of the things we noticed is that we can do this for a little while. We were able to accommodate those patients, but we were very happy to see that the numbers were going down and that we could breathe again. So of course, curious and also anxious about the results, because we all saw that those COVID patients were really, really ill, and a lot of them we couldn't save. So of course we also tracked when the patients were discharged, where to were they discharged? Were they discharged to the ward or were they dead? Now, well, you can see the graph here and already showed you how many patients died in the Netherlands, but I'll show you some more later. There was a big issue, and I don't know if you or anyone else was had the same problem as we, was that all the communication was always about those patients who were discharged. So there was a distorted view on what was really going on. In Europe, the lines with Italy are short, so we could easily talk to our colleagues. And the results, they came relatively quick in personal conversations. But imagine that there were a large part, and that's what you see here as well, a large part, and it's the orange line here, was still in hospital. So you couldn't say anything about their final destination. Then there was another problem which we could solve as being a national registry. We also, of course, had data on severe acute respiratory infections, which of course happen in normal seasons. Flu happens, normal pneumonia happens. So what we did was we took 3 seasons of normal airway infections, and we compared those with the COVID patients. And then we saw, well, maybe we are not doing, it doesn't look that bad. So we're doing quite well. Of course, they're dying, but still it looks a bit the same as our normal patients. There's one big issue here, which I can't show you at the moment, but we will show it later in the paper, and that is when you correct these numbers for severity of illness, then in the Netherlands the SARI patients were much sicker, so they had much more comorbidities than the COVID patients. So in fact, they're doing worse. But this is just something you can easily do when you have a registry and you're able to share this with governmental organizations who are pushing, for instance, to say, should we treat those patients because they're doing not so well? So, well, they're doing, it's not very different from other patients. Then there is this discussion about age. And of course, we could also really easy and fast show what were the patients who were admitted in the ICU and what were their ages. And you see here age cohorts starting from 20, ending at 90. And of course, you see that the results in those patients above 75 are worse than those below that. But one of the other things you see is that there are not a lot of very old patients admitted to the ICU. And there's a big discussion, why is that? Why didn't they reach the ICU? And I remember that I had a conversation with George someday, and we talked about out-of-hospital cardiac arrest, which is a very nice study group, which you could study in your registry and compare with, we compared it with Brazil. And George said, well, we don't have them. I said, you don't have them? You don't have out-of-hospital cardiac arrest? They don't reach the hospital. And they're just not there. And this is what we think happened in the Netherlands with the very old patients. They never reached the hospital. There was so much pressure on, we don't have enough beds in the ICUs that started to talk with their patients on, well, maybe you shouldn't go to the ICU. And we don't know whether it was good or bad, but it is a sort of self-fulfilling prophecy that when you're not admitted, if you don't run the race, you can't win the race. So we need to see what happens when the second wave hits us. So just to wrap up a little bit, odds ratios, of course, go up when you are older. So in the cohort between 80 and 85, you see an odds ratio of almost 25 on of course, the numbers are low here. You see only 7, so this could change over time, but it shows clearly that the risk of dying when you're older is indeed very high. This is what I wanted to tell in a nutshell, what we did with our national registry. On the website of our national registry, if you just go to NICE in Netherlands, you can see a lot of other graphs and stuff we did. And I here have to thank all the ICUs in the Netherlands for sharing their data and helping us and being able to present this here. So thank you.
Thanks a lot, Dave. It's a great presentation. Again, I encourage people to send their questions for the chat. We're going to be able to answer them right after the presentations. So thanks a lot. It was a very nice perspective on how having national registries and core data sets in place and the information structure can help in the moments of the pandemic to rapidly be able to connect ICUs and provide near real-time information that certainly helped a lot in the decision-making process for ICU managers, hospital managers, and the governmental level looking for regions in the country. So thanks a lot. So following, I'm going to do a presentation on challenges for ICU management. Just a second, I'm going to share my screen with you. Okay, so I'm going to talk a little bit about COVID-19 and the challenges for ICU management in the next minutes. So every one of you knows this type of graphs, these type of dashboards. They became very popular, and thanks to the connection of a large number of health systems and information and the IT structures. And here's just to show that actually what we know, this is a global problem. It's not localized. Of course, there are waves. And right now in Brazil, we are in a kind of hotspot for COVID. But just like other countries have been in the previous weeks, hopefully we're going to make it through the next weeks with decreases in cases. Anyway, the important thing is maybe it's the first time that as the ICU community was faced with such a high number of severe cases happening at the same time and with the same diagnostic and the same etiologic agent coming to ICUs all over the world. And this surge of COVID-19 cases certainly poses a very important threat to quality of care and to the ability of intensive care units to deliver adequate and high quality of care for these patients. Some reasons that we believe this could have happened. So first of all, the exceptionally high number of cases that I mentioned, but also that these cases have higher than usual severity of illness, and at least at first, unknown presentations and severity of illness. So the time course of the disease and the clinical course and outcomes were quite unknown in the first weeks. That is very important because the changes in the patient profile coming to the ICUs are very important. Even though, just like they've mentioned, maybe they're not much sicker than the other SARI patients, the fact that we're not having the elective surgery patients, we're not having the cardiac surgery, we're not having the intermediate severity patients coming to the ICU because the ICUs are filled with COVID-19 patients, actually changes the case mix of these intensive care units. When you put this together with the reduced ICU staff, either because we had to increase from one day to another the number of ICU beds, or also because ICU staff, physicians, nurses, the other healthcare professionals were getting sick and were on sick leaves during the period, this poses a very important problem. When you add to this the fact that hospitals were strained with difficulties in bed availability, ventilator availability, I think that when you put all this together, it is clear that it's very hard to keep the same standards as before the COVID during the pandemic, and that potentially will lower the adherence to evidence-based measures. And it's important to understand that when we lower the adherence to these measures, it's very clear that we increase the ICU acquired complications, but we also increase the hospital and ICU lengths of stay, and as a consequence, the mortality rate of these patients. So this is a very important problem. I'm going to focus on at least 4 topics very quickly. So the first challenge that we saw was to ensure bed availability for COVID patients, just like Dave mentioned in his great talk before me. The second one was to understand as we go or on the fly, what were the usual COVID-19 outcomes? What is it that we're actually talking about, and trying to understand and get a measure of are we doing good or not, because that was very hard to tackle in the first place. The third one was the importance of evidence-based measures in the end process of care and how to try to implement them. And of course, if we are to try to understand what we are doing, can we still use the traditional forms of performance evaluation and ICU efficiency metrics that we used before COVID to evaluate our ICU during this pandemic? So that these are the 4 points that we are going through. So the first thing that we saw was the opportunity to help ICUs to ensure that they would at least understand bed availability and resource availability. By that, I mean the number of ventilators, non-invasive ventilators, the alternatives to it, ECMO, etc. So we took advantage of the fact that the EpiMed monitor system is already deployed in a relevant number of ICUs, more than 1,100 ICUs in 7 different countries right now. And we simultaneously deployed this type of dashboard for all ICUs in Brazil, Belgium, all the countries that are using EpiMed monitor at the same time. So what this provided actually was a total number of admissions at the hospital and at the ICU already classified, because just like the Dutch, we had added the SARI definition, the COVID suspected cases and the COVID confirmed cases. So you could track in your ICU what was the actual status for both hospital, all adult ICU beds, and also the pediatrics and neonatal intensive care, which of course were fortunately less affected. And then you could also track the occupancy rates and how much of the occupancy rate was actually represented by these groups of patients. And by filling in information on your own structure, you could actually track what was in use and what was recruitable. That being said, if I have maybe a step-down unit that I can easily convert to critical care if needed, that would be considered a recruitable bed. And the same applied for conventional ventilators, other ventilators, ECMO machines, etc. And then you could track also the resource use. And this was because it's connected to the electronic medical record, and with information coming from EpiMed Monitor, it was near real-time information for ICU directors and managers. Also, we provided ways to analyze in near real time the local trends. So that being said, this would be like the vision of the dashboard that an ICU manager would be looking at his own ICU. So if this is today, and I'm in this hospital, what I'm seeing is that there is a trend towards reduction of ICU admissions, even though the last 2-3 days there were increases in numbers of cases, but not a lot, just 3 new cases from yesterday to today. And then we could track everything, both for the SARI patients, the COVID patients, and the cumulative information on them, also with the outcomes. And again, representing the survivors, the patients that were deceased, and also those ones that remained in the ICU. So very easy to look at and very updated information that would help managers to ensure bed availability, or to look for other sources inside the hospital, or maybe referring the patients to other units if they were actually overwhelmed by these patients. Also, what we tried to do was to provide benchmarking as a source of information that would, again, help you to put information into context and understand the regional caseload. So what we did here with the benchmarking for the SARI COVID patients was to get trending reports. And with the trending reports, you could look at your region, let's say your city or state, and then you would look at the trend. So maybe if I'm in that ICU that I showed before, where there's a trend towards reduction of cases, and I look at what's going on in my region, then I'm just lucky. But in my region, the trend is still of increased daily admissions to ICUs due to COVID cases. And with that, I would understand that maybe it's not the time to close my ICU beds that are dedicated to COVID, or to try to go back to, let's say, normal life, but rather to stay a little bit more cautiously and follow the local trends, because patients are still coming to the ICUs in my region. And that being said, I would still need to be keeping my focus and attention to the possibility that there would be new ICU admissions due to COVID in my ICU. What we also did was to try to give near real-time information to understand outcomes. And then it's very tricky, because you need to have updated information, which that was okay because we did have through EpiMed Monitor, but still one of the important problems was, just like they've mentioned, the fact that lots of the outcomes were not complete. That being said, an important number of patients were still hospitalized when you generate the benchmarking evaluation. And also some retrospective entry of data could affect potentially these results. But in general, we could provide information on the main diagnosis we could go for, and you could just filter and say, I want all suspected plus confirmed. I want the SARI cases. I want the just COVID confirmed cases. And then you would generate benchmarks such as this. So this would be an intensive care unit where I admitted during the period 218 patients, and I'm comparing with other units that had admitted nearly 10,000 ICU patients with confirmed COVID-19 diagnosis. Then I could say that probably my severity of illness was slightly higher than average, and the mortality rates, although high, close to 22%, were actually lower than expected. And in other units, they were not doing as good. So it's a way to track not only your outcomes, but understand them in the context of benchmarking. So we recently published in the UTIsbrasileiras.com, which is the Brazilian ICUs, the National Icu Registry, a partnership between EpiMed and the Brazilian Society of Critical Care, this information coming from EpiMed on COVID patients. So this information is updated until May 15th. So already some time for outcomes. More than 82% of the patients had already complete outcomes in this analysis. And what we show here is data from almost 14,000 ICU beds, where there were 10,500 confirmed COVID cases. And they represented a lot of the occupancy rates. Understand that when we look at occupancy rates here, what we are saying is that in average from March to May, these units had an average 80% of occupancy. But when we looked at the peak in Brazil, that being said, the month of May, both for public and private, this was above 86%. So it's very interesting to track and understand the patient profiles and outcomes, and that's feasible through a national registry, just like Dave Douglas showed us in his previous presentations. So again, we try, if you are in your ICU and you're trying to understand what's your usual COVID-19 profile of the patients and the outcomes, then you can compare your data to this, which is from this large database. So when we look at this type of information, we see that actually in COVID-19 patients, only 41% of the patients had ages above 65. So that changes a little bit on the myth that it's predominantly a disease of the elderly. And also, it's important to stress that both frailty and comorbidities are important in a similar way to what we see in SARI patients. Also, resource use and mortality changed. So it's not here, but you could also benchmark that in the previous period before COVID, the overall use of mechanical ventilation in Brazilian ICUs contributed to this database is close to 20%. In the private sector, close to 15%. In the public sector, close to 40%. And so you can see that even in those that were already at baseline using a lot of mechanical ventilation and dialysis, there was at least 30–40% increases for the public hospitals. But also, it was important to say that there was 2 to 3-fold increases in the private sector. And that certainly had an impact on mortality. So when we look at ICU mortality for these patients, overall, it doesn't look bad, 21%. But when you look at the mortality rates for the ventilated patients, overall, for COVID patients, it's close to 66%. So 1 in 3 patients will survive hospitalization if they require mechanical ventilation for more than 48 hours. And that is a very high mortality, whatever the context that we're looking at. So now that we could see that we provided ways to track and ensure better availability and resources, and that we could understand our better our outcomes, what we tried to do also was to reinforce the need to adherence to evidence-based measures. So in this slide here, what we see is actually what happened to the adherence to low tidal volumes during COVID. So you see that in these units here, we had almost 100% adherence before March. And then when it comes to April and May, exactly when we had the surge of these patients, and perhaps when we needed more to implement low tidal volumes and protective ventilation for these very sick patients, where we know that high tidal volumes will prolong mechanical ventilation, increase lung inflammatory and pro-fibrotic responses, and also mortality, that's what happened. But if this is bad news, on one end, the good news is you can track it. And if you can track it, if you can measure, you can promote change, because this is actionable data that through the implementation of protocols can be changed on a daily basis. And if we remember what happened during the 30 years of research on the ARDS and sepsis, exactly this type of implementation was what changed the outcomes, and not the fancy new drugs on the block. So here is this figure from this paper from our group that was just accepted on Lancet Respiratory Medicine. And what we propose is what would be standards of care and what would be specific considerations to ensure the implementation of evidence-based measures for COVID-19 patients and for ICUs during the pandemic, with a specific focus on mechanically ventilated patients. In brief, what we summarize here is that it's very important to stick to what we know. This is what is already shown also in the Surviving Sepsis campaign paper focusing on COVID patients that was published in Intensive Care Medicine in March this year. So what we have to do, and the best thing that we have to do, is to try to stick to what we know from sepsis and ARDS and translate it into COVID patients until more evidence for use of specific phenotypes or use of specific drugs are available for us. Finally, we should think of how to measure ICU performance. So we were used to, for 30 years, to say, if my standardized mortality rates look good, I'm doing good. If my lengths of stay are okay, then my ICU is an efficient intensive care unit. But that all changes with COVID-19. So we as ICU directors, ICU managers must be aware that crude mortality rates are higher than usual in COVID-19 patients. Even if we say that it's comparable to SARI patients, the overall changes in case mix and the overall surge of high severity patients to the ICUs will increase my average mortality rates anyway. Another thing is that case mix affects mortality rates a lot. So maybe if you have a large number of ICU beds and you still can admit patients early on in the process, you may be bringing in patients with lower severity that will, just like I showed you in the benchmarks for APMED, will give you a lower mortality rates like 21 or 30% of ICU and hospital mortality for all patients. But when you look at the sickest patients, and that's what you should track over time and compare over time in your ICU and with the benchmarks, such as the ventilated patients, then you get a better idea of what's actually happened to the sicker patients. The same applies to lengths of stay. So lengths of stay for COVID-19 patients are up to 50% higher than for the average ICU patients. And even for the ventilated patients, it seems to be a little bit longer. So you have to put the results of your intensive care unit into context. What's your case mix? What's your type of patients? And what has happened over time with your own results and with as the case mix changed in your intensive care unit. Frozen here.
So sorry, I think that we have George has a little problem with the connection. So I'd like to invite you, Geert, to start your presentation. When George come back, we can discuss about it. Some questions that in the chat. Okay.
Yes, thank you. Okay, I will share my screen here. Okay, so I was invited to talk to you about research, and I will discuss how we have organized or set up the different trials here in Leuven. Wait, okay, here we go. So, well, we all know this. This is a new condition that we didn't know yet, and we all see the epidemiology around the world as well. And while in some areas the numbers are declining or stabilizing, there's still some areas, in particular in Southern and Northern America, where there's still a huge increase. So the problem is certainly not gone now. In Belgium as well, we have daily data that are reported to us by the government's official statistical organization called Cienzano. And so until now, we had almost 60,000 confirmed cases. The elderly homes are a particular challenge here. The mortality in Belgium is high, but maybe to our international guests, I must tell you something about mortality. So the mortality in Belgium is counted not only the confirmed cases, but also possible cases. And in particular, here for the elderly homes, you see that most of the mortality are patients that have not been confirmed with COVID, but are suspected of COVID. This is because our government wanted to have operational data. And actually, it allowed us to detect early on in the pandemic that there was a problem in the elderly home. and to take specific measures over there. Because probably our total mortality is a slight overestimation, and it almost coincides with the overmortality in our country. Anyway, in our country, the epidemic is clearly going down now. So this is these are the confirmed new cases per day, and you see that over the past days we have had very few new confirmed cases, even while we test more. And this is the evolution of new hospital admissions. The healthcare system burden was, like in the Netherlands, was high, and we also peaked somewhere in the beginning of April. So these were the patients in hospital, dark green, the patients in intensive care. These are the patients on a ventilator, and the scale doesn't allow you to see it, but the dark numbers were the patients on ECMO as well. These are data from all Belgian hospitals. And as anywhere in the world, and you've heard it here before, it's the burden on ICU that has been very severe. And this very nice paper from Italy, where they had a total collapse at a certain stage in Lombardy of their healthcare system, shows it nicely that you have at a certain stage, you had 1,300 patients on respiratory support, while originally in Lombardy, there were only 700 registered ICU beds. So they had to create a lot of additional capacity. And as I said, this virus is not gone. And so even in the areas where we think we have a decline now, we see that, or we suspect that we will get new outbreaks. And this paper from Science has simulated this, depending on the duration of immunity, that you can even have, in worst case, we could have outbreaks twice a year, but annual or biannual outbreaks seem very rare until they seem very very likely that we will get them until we have a vaccine. And so if we talk about treatments, actually treatments that could reduce the proportion of infection that require intensive care would be very interesting, because that was the most critical resource that we have. And also the reduce the duration of infectiousness, because this way a new case will infect less other cases. Now, when it comes to available antiviral treatments, I think we can get a change in our view on that almost every day. So I think hydrochloroquine, which was the promising drug from the beginning, at best is still unclear, but there's accumulating evidence that shows that it's actually not beneficial or even harmful. Remdesivir has ongoing trials. Kaletra has no impact. Favipiravir is an antiviral drug that is going to set up trials. And in the beginning, there was the idea to do these trials in Belgium. But I've heard yesterday that the trials will move to Brazil, where the epidemic is still more active. So we could say, okay, let's all sit in front of our TVs and do nothing, or we could try to do something and do research. So I will discuss briefly the Leuven trials. There's absolutely no time to get into it deeply, but maybe in the questions we can do this. I will talk a bit about the high security lab of the Rega Institute, and then about our Dawn trials. So my good friend Johan Neitz, who is actually also a bicycle friend of me, I knew him before this pandemic and before we met in professional environment, is running a high level biosecurity lab, which can actually test virus and antiviral drugs without any human manipulation, which is very interesting, of course. He has been funded by the Bill and Melinda Gates Foundation to test thousands of compounds on their potential antiviral activity, and some of these compounds are very interesting for clinical trials. If you want to see a video about his lab, this is his website. He's also working on a vaccine. So he they have a yellow fever vaccine that they could use as a potential vector for the SARS-CoV-2 virus. And the virus works well in an animal model, in hamsters. and we hope that we can take it to clinical trials by the end of the year, although vaccine is highly unlikely within the first year, as he told me. So this is the lab, but as I said, we can interact with researchers at a very high level nowadays, and we can go from the lab to the clinics quite rapidly. And so there were a lot of hypotheses about potential interesting compounds that at the beginning of the pandemic, when it hit us, started here. And the coordination of all these trials was quite challenging. So we decided to run them on one platform, or to take one master protocol that all these trials would use, and we put them under the acronym DAWN, so direct antivirals working against the new corona virus, and also because the term DAWN gives us some hope that at least at the horizon there is there might be possibilities. We have 4 studies now running under DAWN: the antiviral, azitro study, plasma study, where I'm the PI, and the anti-co study. I will go over them briefly. So the antiviral study, so one of the compounds out of the lab of Johan Neitz that seemed to work against the COVID virus was itraconazole. And so we set up a study where we added itraconazole to the standard of care. In the beginning, standard of care here was still hydrochloroquine, but that is likely to change. So there will be, this is hospitalized patients. Patients are monitored in hospital, follow-up day 15, day 30, whether they're still in hospital or discharged, and then 6 weeks post-discharge, and day 90, there is a new follow-up. Now, the trial is currently halted because it was proven to be difficult to get adequate blood levels of itraconazole, but we will see how and when we will restart this study, probably in the next second peak. Second study that was started on the same principle is azithromycin study. So azithromycin also in the lab showed an in vitro activity against the virus. So here as well, azithromycin added to standard of care, and you can see clearly that the follow-up points of our study are the same. The outcomes are also the same, which means we can integrate studies, and also that if we decide to stop a certain arm, like we did now for itraconazole, that the other study can rapidly fill the gap here. The DAWN plasma trial is a trial where I am the principal investigator myself. We changed the acronym a bit for this one, or at least the abbreviation: donated antibodies working against novel coronavirus. Plasma therapy is a very old therapy, as we all in the Spanish flu epidemic. It was even already used in the 19th century against the whole number of viruses, never with very good evidence. For the previous SARS epidemic, we know that there was a good safety profile and that there was a decrease in mortality. For Ebola, there was one trial using a historical control group that was led by Jo van Griensven of the Tropical Institute in Antwerp, where they saw no benefits overall, although there was a possible benefit in young children and pregnant women, but a very good safety profile for of this therapy. They did not know the level of neutralizing antibodies in their plasma. Yesterday, there was a new trial from China that was halted prematurely because they were not able to recruit more patients. A bit more than 100 patients were randomized. There was no evidence for the whole group of patients. So overall, there was in time to improvement, there was no, which was their primary outcome, there was no benefit of convalescent plasma, although in the patients with severe disease, they saw a significant effect. And so there might be some hope that adequately powered studies such as ours, hopefully, are able to demonstrate an effect, because this therapy, of course, is widely available across the world as more patients will have the disease and will have antibodies. We did this together with the Red Cross, because the Red Cross in Belgium is responsible for collection of blood and also for actually producing the safe units. So there's a website where donors can register the 7 questions. If they feature, then they get called by a donor center for plasma donation.